Hello, everyone, and welcome to another insightful episode of MedSynapse podcast series. Today, we are diving into one of the most high pressure yet life saving areas of medicine, which is trauma resuscitation. Trauma can strike anyone, anytime, and having the right approach in those critical moments can make all the difference between life and death. And joining us is an extraordinary guest who has dedicated his career to excelling in this field, Dr. Rupesh Bokade. Dr. Rupesh is the consultant and head of Department of Emergency Medicine at Kingsway Hospitals. With advanced training, including DNB in emergency medicine and certifications from prestigious institutions like AIMS and Royal College of Emergency Medicine in the UK. He's a leading voice in trauma and critical care. So, Dr. Rupesh, thank you so much for being here, and it's such a pleasure to have you here with us today.
Thanks for the kind introduction.
So, Doctor, let's begin with your journey in trauma care. I'm very interested to know about that. What inspired you to specialize in trauma resuscitation? And could you share some memorable experience that shaped your approach?
Yeah. This started early in my medical training. Okay, when we were in the internship post MBBS, we used to get many trauma patients.
Mm-hmm.
Okay, and after doing structured clinical evaluation, we used to save them. But the thing is that the high pressure, the adrenaline surge, and critical thinking while managing such kind of patient, the polytrauma patients, are crucial. And these are the decision maker and these are the life savings. Okay, sometimes the team approach, we require a team of multiple disciplinaries like the surgery, vascular surgery, the orthopedic surgery, the anesthetists, the emergency medicine, the multidisciplinary approach. And the main is the like appropriately timely intervention, which will save the life. These are the difference between the life and death. And by
Mm-hmm.
doing such things, which we give the immense pleasure and the satisfaction while doing such great work in the trauma, which has outcome, the what we can say, the long-term outcome. We can make the patients good impact on the long outcome of the patients and the life survival. So these are the things which attracts me.
Yeah, actually, it's inspiring to hear your story, and I think trauma is the one emergency medicine in all is actually a field where the physician has to be on their toes 24 by 7. Now, speaking of saving lives only, doctor, trauma resuscitation relies heavily on primary and secondary surveys. So, could you walk us through the key components of these surveys and also touch upon how ALTS guidelines play a pivotal role in today's trauma care?
So if we come across any polytrauma patient in our emergency
Mhm.
department, so these are the structured approach. The ATLS is the Advanced Trauma Life Support Program, which give us a structured approach and protocolized approach how we go ahead with the evaluation of the patient. So there are the two surveys. First, the primary survey and the secondary survey. Mostly, primary survey deals with the immediately life-threatening situations. We have to deal with immediately life-threatening situation. We have to treat it and go ahead. Secondary survey is a head-to-toe examination. So, what is there in the primary survey? In the primary survey, we have to check for the airway first because it will kill first. So, what kills first? We have to treat first. So, airway with cervical spine stabilization. Then breathing and ventilation, the oxygenation thing. C is a circulation and definitive hemorrhage control. D is a deformity. Okay, we have to check for the GCS, any focal motor weakness, and E is a exposure. We have to expose the patient and simultaneously prevent the hypothermia. Okay, because hypothermia, which can trigger the triad of death, which is hypothermia, coagulopathy, and hypotension. And this thing is a triad of death. In secondary survey, once we finish this, we have to move to the secondary survey. But before moving to secondary survey, we have to repeat ABCDE again. Once we are sure with ABCDE has been taken care of, then you can move to the secondary survey. Secondary survey is a head-to-toe evaluation. We have to check each and every corner of the body. We have to log roll. We have to do all the investigation if required. Okay, like fast, CT scan, X-ray in the secondary survey. If any missed injury is there, we have to find out in the secondary survey. Okay, and then we have to treat it. If there is a requirement of any another specialty support, we have to call them immediately.
Correct. I think the structured approach of ATLS does seem like a game changer. Now, Doctor, moving on to your most challenging aspect also that you mentioned earlier, as well as airway management in trauma patients. So, what are some of the biggest hurdles you have faced while securing an airway, and how do you manage to overcome them in such high pressure scenarios?
Yeah, so this is the nightmare for us. Okay, so airway is like unpredictable. Each and every patient is a different for us. Okay,
True.
it is a very challenging thing, and if we failed to secure the airway, patient will
Mhm.
die soon. Okay, such kind of patient doesn't give us a time more. Okay, so we have to assess whether there is a requirement of securing the airway, and securing the airway without giving secondary harm. Okay, without causing secondary harm, because hypoxia, hypovolemia, hypercarbia, this causes the secondary trauma to the patient, secondary harms. So many of the patients who come to the trauma center of ours, we don't know what is the last meal have they taken. Okay, whether is a patient full stomach, patient has a maxillofacial injuries, patient has multiple facial bone injuries, patient has bleeding through the mouth, or patient has avulsed teeth which has gone into the airway. Okay, such patients airway is very difficult. Okay, we have to secure, and simultaneously we have to maintain the cervical spine as well. We have to stabilize the inline stabilization of cervical spine. That means we can't move, or we can't excessively move or make the unstable cervical spine. Okay, and in that case we have to secure the airway. So many of the patients are pregnant, they are obese, they have maxillofacial injuries, bleeding from the mouth, difficult mouth opening, very narrow mouth opening. So these are the challenges we come across day in and out. Okay, and how we come across. Okay, so there is definitely a team management. Okay, it's
Mhm.
a team. I have a very exceptional team, which are the backbone of our department. They know in such crucial condition how to manage the airway and how to support the airway. Okay, so what we do, there are many things. The rapid sequence intubation is there. Okay, there we sedate the patient and intubate the patient by giving the short paralyzing agent. If the patient is very difficult and not able to intubate, then there is a laryngeal mask airways, LMS we use. If the patient, again, there is a difficult airway, there are many adjuncts. Okay, the video laryngoscope, the fiber optic scope. Okay, uh, we try to use these kind of technology, the newer technology, the video laryngoscope, the fiber optic scope. Okay, and definitely, if after doing all the things, if it is not feasible or difficult to ventilate and difficult to intubate the patient, like can't intubate, can't ventilate, then the surgical airway comes in, like surgical cricothyroidotomy. Okay, there are special gadgets for it. The surgical cricothyroidotomy kit is available commercially nowadays. Okay, and I think each and every emergency department should keep the surgical cricothyroidotomy patient where there is a need for surgical airway. These are the time buying things. You can buy the time till you can definitely secure the airway. Okay, after surgical cricothyroidotomy, another things, you call for help. Okay, if you are not able to do intubation or not able to ventilate the patient, definitely your anesthetic colleague can help you. So it's a team approach, and airway, what we can say, is a challenging things. Okay, it is a multimodal approach. Each intubation is newer for us, and after doing all the things, we debrief each and every after securing the airway.
Yes, I think that's a valuable insight, and airway management is truly such a critical component. And I think with team management and team collaboration, it is rightly managed as well.
Even nowadays, I want to add one point. Even nowadays, there is a pre-oxygenation thing. Okay, we have to pre-oxygenate the patient by using. We are using HFNO, high flow nasal cannula. We have to pre-oxygenate. That means denitrogenate the patient, so we can buy some time while intubating the patient. We can buy the apneic time. Okay,
Hmm.
so we have to pre-oxygenate well patient, well pre-oxygenation, so that we can buy some time while we can take the much more attempts in such
So
things.
there are newer and newer techniques coming in to
Coming,
help. Yes.
yeah.
So now, doctor, let's shift our focus to managing massive hemorrhages because they are also crucial components. So, could you share the latest strategies you've been using, particularly damage control resuscitation and massive transfusion protocols, and how are these evolving in trauma care?
So, in any trauma patient who is a hypotensive,
Hmm.
is having hemorrhagic shock until proven otherwise. Okay, patient coming
Hmm.
with the shock of trauma patient is having hemorrhage. So
Hmm.
first we have to maintain the map so that we can perfuse the vital organs like kidney, liver, brain, and heart. Minimum 70 to 75 or 60, at least 60 to 65 mmHg of map, that is a mean arterial pressure. We have to maintain the blood pressure. Whenever the patient comes in the hypotension, we have to secure the two broad cannulas. Okay, uh, we have to give the at least 1 liter of ringer lactate or the balanced custard solution. And if there is the requirement of more fluid, then you should alert your lab, the blood bank, that that patient may require massive blood transfusion, and ask the more blood bank. Okay, because diluting the blood will also dilute the coagulation factors, will also dilute the platelet as well, so that the thrombosis, the forming thrombosis or the hemostatic property of the blood will not achieve. So minimum dilution of the blood with the IV fluid and maximum giving the blood. Okay. So what we do, there is a concept called permissive hypotension. Okay. So when there is a patient who comes with the hypotension, we achieve maximum systolic is a 90 to 100 mm of Hg is a systolic. Okay. If the patient of the head injury is there, then we should achieve more, that is more than 110. Okay. But permissive hypotension till we source control. That means whichever is the bleeding source, we have to achieve that. We have to stabilize that. We have to control. Okay, control the bleeding first. Till that, you can achieve the permissive hypotension. That is a one strategy. Second is, as you said, the massive transfusion protocol. Whenever there is a requirement of more than 10 PRBCs in 24 hours, we call the massive transfusion protocol. Okay, or more than 3 or 4 PRBCs in a 3 to 4 hours, that means patient is going to require the massive transfusion. In initial hours, we can ask for the O negative blood, okay, because it can come within a minute, within 10-15 minutes or half an hour, we can say as early as possible. We transfuse such blood without checking the ABO compatibility and group matching. We send the blood for the CBC, PTINR, TAG, rotaine, and blood group cross matching. Till the time we get blood group specific blood, we use O negative in a pregnant patient or the young female patient, and O positive in a male patient we can use if it is O negative is not blood available. Massive blood transfusion protocol is using 1 is to 1 is to 1 ratio. One PRBC, one plasma, and one platelet. This is how we achieve. Is equivalent to the whole blood. And in short, it is equivalent to whole blood, which has all the clotting and clotting factors and the sufficient amount of the platelet, which can control the bleeding by forming the thrombus. These are the things which we required. Second, in any massive transfusion protocol, we have to check for the calcium as well. We have to replace the calcium. Simultaneously, as I said earlier, we have to prevent the hypothermia, because acidosis, hypothermia, and hypotension is the triad of death. So these are some situations where we have to be on toes. Simultaneously, we have to do the fast bedside check for the source where the patient is bleeding. Many of the time, it is a solid organ injury like the thorax or the what we can say liver, spleen, kidney. These are the solid organ injury where we see the fast positive, and we call the trauma surgeon immediately, and we immediately alert the OT operation room and shift the patient for definitive damage control. Okay.
Yeah, thank you for breaking that so well. And I think there are different factors, like you also mentioned, that come into picture when controlling hemorrhages or massive transfusion. So thank you for breaking that down. On a related note, only doctor, many trauma care centers around the world face resource limitations. So what advice would you give to healthcare professionals working in such settings to adapt to protect protocols while still ensuring patient safety and optimal outcomes?
Yeah, very good question. Even some of the times we also face such situation where mass casualties or the disaster is there,
Hmm.
where the resources are less than the patients. Okay, so what we do, there is a stick to basics. Okay, it is not much of a science behind it. Triaging the things. Okay,
Hmm.
triage is giving the priority to the patient who require the most health care.
Hmm.
Okay, if the patient comes to you and who is a salvageable, and he satisfies all your triage, you triage the patient accordingly, like red, yellow, and green, according to your triage scale. Most of the hospitals has the Canadian triage, Australian triage. In the field, there is a star triage. Any scale you can use. Triage the patient who require more help and who will be benefiting by your intervention, you use it. Team approach, each and every of your team member should know their role according to their strength. Assigned role, so many of the time I declare myself as a team leader. I know my team. In such condition, I ask extra help from the another department and the colleagues, okay, of different specialty. I assign the role to them, and they know how to manage that role, and they are excellent team. Okay, uh, uh, if each and every member follow what they are supposed to do, then I think in such situation we can manage the patient very well. Okay, there should be clear instruction. There should be the closed loop communication. Okay, you should involve all your superior authorities, even the hospital management as well in such condition, and focusing on what is the patient need. I think that is a sufficient to tide over such situations.
Now, doctor, finally, trauma resuscitation often demands quick decisions. So, how do you balance the need for rapid decision making with avoiding over intervention or unnecessary procedures?
So basically, in such situation, as I said earlier, it's a structured and protocolized approach should be there. We generally, while approaching the trauma patient, we follow the ATLS rule, ATLS guideline. That is a primary survey, secondary survey. The team is there. Our crash room is ready. Our blood bank is notified. I declare myself as a team leader. I assign the role to each and every the airway person, the drug person, the triage nurse, no, the timekeeper. Okay, even the anesthetist, even the OT, even my focus, the point of care ultrasound is ready. Okay, so this will prevent the over interventions. Okay, we should focus on the priorities like airway, breathing, circulation, deformity. Once you clear all the things, then it's come to the secondary survey. Okay, there should be the proper communication between your team member. There, yeah, any team member can definitely structurally intervene whenever he feels that anybody is deviating from the uh, uh, way. Any of the team member respectfully can intervene, and after successful resuscitation, or each and every resuscitation, I debrief. So what is a debrief? This is what we can say. This is a team building thing.
Mm.
In debriefing, there is a what are the things which went right, and what are the areas we should improve for our next patient. Okay, and for each and every successful resuscitation, even the failed resuscitation as well, we debrief the team. Hence, how we continuously building ourselves, we improving ourselves, and we are adopting new technologies. This is how we go ahead in such scenarios.
That's a really nice piece of advice, and I think that also helps each team member to focus more on their role and what can be done in especially such fast-paced environment also. So, Doctor, thank you so much. This has been an incredibly enriching conversation, and your experience and insights into trauma resuscitation are not only informative but also inspiring. So, thank you so much for sharing that with us today.
Thank you so much.
So, Doctor, before we sign off, is there any key message you'd like to share with our listeners today?
Yes. So, key message is there are two, 3 points I will say.
Hmm.
Never forget the basics. Okay, anatomy,
Okay.
physiology is the behind is the main thing you should be focused on. Structured approach of ATLS, the primary survey, secondary survey. Don't deviate. Don't deviate by seeing the blood. First secure the airway, then see. First airway, then see. Okay. There is a team approach. The alone. Okay. One person, even though he's the most skilled, can't save the life. Okay. There is always a team behind saving the life. Okay. These are the three messages I want to give.
Those are some really insightful messages. So, thank you so much for sharing that with us today, Doctor. And thank you for being here with us today. And to our listeners, thank you for tuning into this episode. And remember, if you are a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate to join us on the MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, stay safe and take care.